I would like to thank AIOS for giving me this opportunity to speak as a keynote speaker in the pediatric session. I am presenting the paper which I had presented last year and got the best paper award. So the topic is effect of low dose atropine and choroidal thickness in children with myopia progression. I have no financial interest to disclose. So the purpose of the study was to determine the effect of low dose atropine on choroidal thickness in children with myopia progression, to compare the rate of myopia progression in cases versus controls in terms of changes in the spherical equivalence, axial length, best corrected visual acuity, choroidal thickness at presentation, and subsequent follow-ups. This was basically a prospective single-blind case control study conducted in the Department of Ophthalmology, KIMS Bhubaneswar. We took 110 participants aged 5 to 16 years with bilateral progressive myopia, out of which 44 cases and 43 controls were included, and the rest were excluded as per the exclusion criteria, which include patients who were allergic or hypersensitive to atropine, those having any systemic disorders, with poor compliance to atropine use, astigmatism more than 2 diopters, uniocular progressive myopia, patients who were using other forms of anti-myopia therapy like ortho-K, any dose of atropine or pyrazine, any retinal pathology like ROP, other ocular morbidities, and patients who were lost to follow. So 87 children were randomly assigned into 2 groups. The 88 eyes of 44 children in group A received once daily dosing of 0.01% atropine at bedtime, while 86 eyes of 43 children in group B received once daily dosing of a placebo, mostly a topical lubricant at bedtime. The best corrected visual acuity, spherical equivalence, axial length and choroidal thickness, both subfoveal as well as at 1500 and 3000 microns in the superior, inferior, nasal and temporal quadrants were documented at baseline visit, 1, 3 and 6 months of follow-up. The statistical analysis was done and a p-value of less than 0.05 was considered to be significant. Now coming to the results. There was a female preponderance in the cases, whereas a male preponderance in the controls. The mean age of both the groups were almost comparable. As we can see here, on comparing the spherical equivalence between the cases and controls at presentation and follow-ups, at 3 and 6 months of follow-up, the cases showed a decrease in the spherical equivalence, whereas there was an increase in the spherical equivalence in the control group, and that was statistically significant. Similarly, in the axial length in cases and controls at presentation and follow-ups, there was significant decrease in the or reduction in the axial length in the cases at 3 and 6 months of follow-up, whereas there was increase in the axial length in the control group. On comparing the subfoveal choroidal thickness between the cases and controls, at 3 and 6 months of follow-up, the mean subfoveal choroidal thickness was increased from 295.36 plus minus 37.63 to 300.38 plus minus 38.13 microns in the cases group, whereas it decreased in the controls from 295.27 plus minus 36.18 to 288.16 plus minus 34.04 microns, and this was statistically significant. Similarly, in the trend of the best corrected visual acuity in log-my units, we can see there was an improvement in the best corrected visual acuity in the cases group from 0.2 to 0, whereas it was reduced in the controls from 0.2 to 0.25 log-my units. The correlation of spherical equivalence and axial length with choroidal thickness was done in the cases and controls, and there was decrease in the spherical equivalence as well as decrease in the axial length, which was correlated significantly with with the choroidal thickness in the cases group, but it was not significant in the controls. So coming to the discussion, the outcomes of the study where there was a significant decrease in the spherical equivalence and axial length at 3 and 6 months of follow-up. Low dose atropine significantly increased the subfoveal choroidal thickness as well as choroidal thickness in all the quadrants, and there was significant improvement in the best corrected visual acuity. These were some of the studies where they have concluded that low dose atropine caused a slight thickening of the choroid in young healthy myopic adults. In a study by Wu et al., they found that low dose atropine at 3 months follow-up, there was significantly increased subfoveal choroidal thickness, and they found significant relationship between the changes in the subfoveal choroidal thickness with central corneal thickness. So the limitations are, it was a small sample size with lesser duration of follow-up. Other risk factors for myopia progression were not taken into account, and CCT, ocular blood flow and pupil size as well as accommodation amplitude were not measured. So to conclude, low-dose atropine is effective in retarding myopia progression by increasing the choroidal thickness, decreasing the axial elongation and spherical equivalence, as well as improving the best corrected visual acuity with no significant adverse effect. And there is a need for the further studies in this regard. These are my references. Thank you.
Thank you, Dr. Shrutakirti. Now we go to the competitive session. I call upon Dr. Navjot Kaur. Can you have the slides, please?
Can we restart the timer?
Please stop.
Good afternoon. Today's discussion concerns leading and preventable cause of blindness in premature infants. This interventional study was conducted at our center, Army Hospital RNR, which is completed recently, and comparison of two intravitreal anti-VEGF, that is drugs ranibizumab and aflibercept, was done in the given concentrations. What is ROP? It is retinopathy of prematurity, a vasoproliferative disorder seen in prematurely born infants. A child is not born with it, but develops it after birth, hence a preventable disease. The incidence in premature babies is 16 to 17% overall, and 68% of ROP is seen in babies born with birth weight less than 1250 grams. 80 to 100% of infants born with birth weight less than 900 grams and gestational age less than 25 weeks can develop ROP. The disease is also prevalent in nations with well-developed neonatal care. So global burden also increases with that. Vascular endothelial growth factor, responsible for the development of vasculature, plays a major role in the pathogenesis of this disease. It involves two phases. In phase 1, there is cessation of VEGF due to hypoxia, and in phase 2, there is upregulation of VEGF and angiogenic factors leading to neovascularization. As per AIOCMT3, the staging of this disease may look complex, but this slide just explains that if vascular proliferation goes unchecked due to VEGF production, it leads to contraction of retina, which is further leading to complications like retinal detachments and blindness. This is the reason emphasis is laid down on early screening, 30 days post-birth, which is also advocated by WHO and Government of India. In NICU settings, this can be carried out earlier. Management, it can be done either with laser photocoagulation or with intravitreal anti-VEGF, which is the trend being followed these days. So what do anti-VEGFs do? They act by inhibiting vasoproliferation and restoring the normal retinal function. The options available with us are bevacizumab, ranibizumab and aflibercept. We chose two drugs, ranibizumab and aflibercept, because bevacizumab is yet not approved for ROP. Based on the previous trials, which involved comparison of laser treatment and anti-VEGF like BEAT ROP, Rainbow, and with advent of newer molecules, this prospective interventional randomized controlled trial was conducted with ethical approval, which involved single blinding. CTRI approval was received in June 2023. The inclusion criteria included any children with presence of zone 1, any stage ROP with plus disease, presence of zone 1 with stage 3 ROP without plus disease, presence of zone 2, stage 2 or 3 ROP with plus disease, infant with aggressive ROP. So this was the design. 456 eyes of 228 infants were screened and 180 eyes of 90 infants were selected, out of which 88 infants were randomized and injected with either of the drugs based on the computer program. So results, these were my baseline parameters. Aggressive ROP cases in the both the groups in aflibercept and ranibizumab. As you can see, the number of injections in the aflibercept group were lesser than the number of injections required in ranibizumab group, and regression of the disease also. Also, none of the infants required a subsequent third dose in the first group, that is the aflibercept one, and even the rescue lasers were less. More eyes showed regression of disease to peripheral zone 3, hence decreasing the risk of blindness in the aflibercept group. And similar results were observed in regression of the staging as well. So previously I showed one of the case, and this was after injection, day 0, day 7, this is the right eye, and day 56, and similarly the left eye. Most importantly, the visual prognosis also increased in terms of unlasered retina, and it was superior in aflibercept group. And we could prevent the zone 1 lasers. Final results showed regression of disease after injecting aflibercept and was non-inferior to that of ranibizumab. So my take-home message in this, anti-VEGFs are effective in preventing progression of ROP, and aflibercept 1 mg in 0.025 ml is as efficacious as 0.25 mg in 0.05 ml of ranibizumab. Also, we can prevent the central lasers, zone 1 lasers, hence giving a better visual prognosis to the children. Thank you.
I have a query, Dr. Munjal. I just wanted to clarify, how did you do single blinding interventions? In your case, how was single blinding done? You mentioned that.
Ma'am, only the person who was injecting did not know which injection was being.
Only the person?
The doctor. Yes, only the one person.
So the investigators were aware?
Yes.
The investigators were
Yes.
aware?
Yes.
So that person is not an investigator who was giving the drug?
No.
Okay. So we move on to the next. I call upon the presenting author, Dr. Akansha Prabhu, to present the case report of retinopathy of prematurity with glaucoma.
Good afternoon everyone. Today I will be presenting a case on ROP with glaucoma. So as we know, ROP is a potentially blinding disease affecting the retinal vasculature of preterm babies and is emerging as an important cause of childhood blindness worldwide. Management of advanced stages of ROP include laser photocoagulation, intravitreal anti-VEGF, scleral buckling, lens-sparing vitrectomy and lensectomy plus vitrectomy. Glaucoma is a well-recognized complication of ROP that may be associated with immature development of anterior chamber, ROP itself, or as a complication of ROP treatment. There have been various cases reported where ROP-treated eyes have shown shallowing of anterior chamber due to pupillary block or due to synechiae. So this complex etiology of glaucoma in patients with ROP emphasizes the importance of glaucoma screening in both short-term and long-term cases in treated and untreated eyes. So the aim was to report a case of a 4-month-old male infant with zone 2 stage 4A ROP associated with glaucoma. The baby was born at a gestational age of 32 weeks 1 day via LSCS in view of antepartum hemorrhage, and he weighed 2 kilos. He had a weak cry with a heart rate less than 100 beats per minute and was hence kept on bubble CPAP with 30% FiO2 and 6 PEP for 8 days. On routine ROP screening, he was diagnosed to have both eyes zone 2 stage 4A ROP, for which he underwent right eye lens sparing vitrectomy plus endolaser followed by left eye panretinal photocoagulation. On subsequent follow-up, mild corneal haze was observed in the right eye, for which IOP was 38 and 12 mmHg in the right and left eye respectively. Other parameters were Y to white was 12 mm in the right eye, axial length 23.38, ACD of 3.21, whereas left eye had an Y to white of 11 mm, axial length of 19.5 and ACD of 3.10. Fundus examination was normal in both eyes. Gonioscopy under sedation showed peripheral anterior synechiae superiorly and temporally, and Schwalbe's line was seen in the nasal and the inferior quadrant. Left eye gonioscopy was normal. Therefore, the child was started on dorzolamide plus timolol, 1 drop right eye BD, and he underwent right eye combined trabeculotomy and trabeculectomy under GA. Intraoperatively, after the eye was cleaned and a speculum was inserted, a limbal based conjunctival flap was raised. 4 by 5 mm was marked on the sclera and a partial thickness scleral flap was created. following which the Schlem's canal was identified, a radial incision was placed and a trabeculotomy was done, following by which trabeculectomy and iridectomy was done. The scleral flap was sutured with 10-0 epsilon, cornea of the conjunctiva was sutured with Vicryl, and then the eye was patched. Postoperatively, the child was noted to have an IOP of 10 and 12 mmHg in the right and left eye respectively, and he was started on tapering doses of antibiotic steroids. Subsequent follow-up, IOP was within normal range and the child had a stable retina. So treatment of ROP has known complications such as cataract, inflammation, vitreous hemorrhage, retinal detachment and glaucoma. So the pathogenesis of glaucoma and ROP has various proposed mechanisms, including the incomplete development of the anterior segment and angle closure. It is attributed to pushing of the lens iris diaphragm forward by the retrolental tissues as well as pupillary block or neovascularization. In this case, it is quite possible that the endodevelopment of the anterior chamber as well as the ROP may have put the child at an increased risk of glaucoma, which was then exacerbated after vitrectomy. Hence, a careful anterior segment examination in ROP must be done to rule out glaucoma risk factors. In conclusion, the multifaceted complications associated with ROP and its treatment, particularly the heightened risk of glaucoma, highlight the importance of vigilant monitoring. By better understanding this intricate relationship, ROP and its complications, healthcare providers can better navigate the challenges in managing these vulnerable patients. Thank you.
Why do you think only one eye developed glaucoma?
It's quite possible, maybe because after the vitrectomy he developed a glaucoma, like an angle closure glaucoma. So the lens, like in pediatric age group, the lens is more spherical. So maybe there was a pupillary block, but
How do you, trabeculotomy is useful here? Already PAS, you said gonio, there was PAS.
PAS, yes ma'am. So generally you also get trabecular dysgenesis along with an angle closure. So that's why we went ahead with the trabeculotomy and the trabeculectomy.
This is not a primary glaucoma,
It's not a primary glaucoma.
We call upon the next presenting author, Dr. Deepti Joshi. She will be presenting on correlation of intraocular pressure with central corneal thickness in premature and full-term infants.
Good afternoon, everyone. Thank you for giving me the opportunity to present. My topic of presentation is intraocular pressure and center corneal thickness in preterm and full-term newborns in tertiary health care center of rural India. Coming to introduction, there is a fluid pressure inside the eye which is known as intraocular pressure. Intraocular pressure is maintained through the delicate balance between aqueous humor production and its drainage through the trabecular meshwork. In context of glaucoma diagnosis and management, the clinical significance of center corneal thickness is well acknowledged. Measuring the intraocular pressure is crucial for diagnosing and treating optic nerve disease. CCT is a factor that impacts the measurement of IOP and should be taken into account when interpreting IOP result. Higher the CCT, falsely high the IOP and vice versa. Congenital glaucoma is characterized by elevated intraocular pressure with alteration in the optic nerve head and structural abnormalities of the eye. Premature neonates have higher CCT as compared to the full-term newborns. This thickness gradually diminishes over the time. There has been gradual decrease in intraocular pressure along the CCT. Material and method. This study is a prospective observational study and it was done in Pediatric World and NIC of Pediatric Department, and study duration is for 1 year. Total 50 premature and full-term newborns are taken in study, and IOP measurement was done by tonopen and CCT measurement was done by ultrasonic pachymeter. Patients were divided into two groups, Group A and Group B. Group A consists of premature newborns with gestational age less than 37 weeks, and Group B consists of full-term newborns with gestational age more and equal to 37 weeks. Inclusion criteria include the patient with admitted in pediatric ward and NICU with gestational age less than 37 weeks for premature infant, and for term infant gestational age equal to or more than 37 weeks, and patient attendant who are interested in participating in the study. Exclusion criteria includes corneal and iris alterations, congenital cataract, ROP, congenital glaucoma, and patient with major organ dysfunction or a syndrome, or with the factor possibly affecting the IOP, like patient on mechanical ventilation or pulmonary or circulatory complications. This is the chart for premature and full-term newborns. Total 29 premature newborns are included in the study, and 21 term newborns were included in the study. Result: the mean age of measurement was 33 plus minus 2.1 week for preterm newborns and 38 plus minus 2 weeks for term newborns, and comparison was statistically significant, p-value less than 0.01%, and the mean birth weight was 1578 plus minus 324 grams in premature, and for mature it is 2.8 gram, and the mean intraocular pressure was 19 plus minus 3 for premature, and for term newborn it is 17.1 plus minus 2.4 millimeter of mercury, and it was statistically significant, and CCT was also statistically significant with values in 589 plus minus 35 millimeter in premature, and 568 plus minus 25 millimeter of with millimeter in micrometer, in full-term newborns. This is the table depicting the same. Coming to discussion, there is limited amount of data is available on center cornea thickness of preterm and full-term children during the neonatal period. Hence, the present study was conducted among 50 patients to assess the correlation between the center cornea thickness and intraocular pressure. Measuring IOP is the crucial evaluation for diagnosing and treating the glaucoma. The measurement of IOP is a crucial indicator for diagnosis and treatment of ocular hypertension, refractive error, and newborn glaucoma. So take home message is in premature newborns, IOP measurement was slightly greater than full-term newborns because of increased CCT. Low birth weight appears to be distinct and separate factor contributing the higher CCT. Cornea thickness decreases as the individual ages, and the reaches at the level comparable to the full-term newborns after some time. In eyes without other glaucomatous alterations such as with higher IOP value cannot be considered as the pathological. These are references. Thank you.
What type of glaucoma is common in children?
I'm open and congenital.
Correct. So congenital glaucoma, it doesn't come under corneal thickness is immaterial, isn't it? So, I mean, the adult pachymetry, we correlate it for the IOP. Do you think we can extrapolate it to the pediatric group? Whenever we see a pediatric consultation, how often we check the intraocular pressure?
Rarely.
Rarely.
Intraocular pressure.
Yeah.
That's
But
why
it's a nice observation that there is a difference in the thickness in the cornea of the preterm and the full-term.
even in full-term newborns, center cornea thickness is slightly high as compared to the adult population. It is 568 in our study.
Agreed. I mean, it's an observation, agreed. But I mean, like a practical application is this is what.
Yes.
Which stats you utilize for this correlation?
Yes, ma'am.
Which statistical test you utilize for this?
Which statistical test you utilize for comparison?
Ma'am, t-test.
Which t-test? No, you don't know.
So we move on to next.
Yes, okay.
So we move on to next.
Thank you.
I call upon Dr. Nisha Yadav.
Nisha Yadav from RP Center AIMS Delhi, and I'll be presenting my free paper on artificial intelligence based active dioptic therapy versus part-time occlusion in cases of anisometropic amblyopia. I'm not able to move it. Yeah, sorry. There is no conflict of interest to declare on these slides. As we all know, one of the newer emerging modality in the treatment of amblyopia is binocular perceptual learning approaches, often referred to as binocular or dioptic treatment, which involves splitting of visual stimulus elements between both the eyes. Dioptic games give binocular stimulation that rebalances the contrast between the two eyes to overcome suppression, and have been reported to induce improvement in visual acuity and sometimes binocularity and stereo acuity, in which the amblyopic eye elements are presented at a higher contrast and the non-amblyopic eye elements at a lower contrast, and finally the intraocular suppression is overcome, and which enables simultaneous perception. The aim and methodology of the study, it was a prospective randomized intervention study done at RP Center AIMS, in which patient fulfilling the inclusion criteria, which included patients between the age group of 5 to 16 years having an anisometropic mild to moderate grade of anisometropic amblyopia, who were treatment naive and had ready availability of laptop at home for daily access, and patients willing to give consent were enrolled and divided into two groups. Randomization was done. The group 1 received dioptic therapy for 1 hour per day for 6 months, and group 2 received occlusion therapy for 2 to 6 hours for 6 months, and following which follow-up was done at 6 weeks, 3 months and 6 months. Coming to the results, the best corrected distant visual acuity improved in the occlusion group and the dioptic group at the from baseline to 6 months with p-value significant. Similarly, the mean near vision between both the groups at baseline, it improved at the end of the intervention with significant p-value. The contrast sensitivity, as we can see, intra-group it improved in both the groups, but the difference was statistically significantly better in the dioptic group at the 6 months with p-value significant when compared to the occlusion intervention. And the binocularity, by Pagolini test, we concluded that almost 100% patients in the dioptic group attained cross response at the end of 6 months, whereas 80% received cross response in the occlusion group. The stereo acuity, both distant and near stereo acuity, in the intra-group, it improved in both the groups from baseline to 6 months, but statistically significantly better improvement was seen in the dioptic group at the end of the intervention. The secondary aim of the study was to check for compliance in both the intervention, and we concluded that 28 out of 30 children, that is almost 93.33%, in the dioptic group were compliant for playing the video game, which was assessed by monitoring their scoreboard and seeing their online progress periodically, as we all can see in the diagram. Because of the online availability, we were able to access to their, we were able to review the patient's progress on a daily basis, and we were able to enforce compliance. And 22 out of 30 children, almost 73% in the occlusion group were compliant for patching, which was assessed by asking questions to the parents and observation done at home. Compliance was reinforced in the patching group by regular parental counseling and motivation. To conclude, the best corrected visual acuity and near vision improved with both the intervention and was comparable at the end of the intervention at 6 months. Whereas stereo acuity, contrast sensitivity and binocularity were all improved in both the groups. However, statistically significant better improvement was seen in the dioptic intervention at the end of 6 months. The compliance was better in the dioptic group due to regular monitoring of the scoreboard and more engaging and varied games given to the children. And hence, we conclude that regular enforcement of compliance is required in both the groups, and dioptic therapy is a good alternative in terms of binocular vision and quality of vision. Thank you.
Was there any difference in the refractive error between the two groups?
No,
I mean, where the refractive errors were comparable?
yes, ma'am. Majority in both the groups, the simple hypermetro patients were more. It was comparable in both the groups.
And other things is that you said 16 years. How many in that above 10 years improved?
Ma'am, the mean age was around 10.58 and I didn't divide it into
No,
subcategories.
because your inclusion criteria was up to 16 you are included.
Yes, ma'am, 5.
So at that age, do you expect any of either of the two to work?
Yes, ma'am. Actually, not in my study, but a similar study we held at RT Center in which we included adult patients with a mean age of around 21 to 22 years, in which we concluded at the end of 6 months that the distant vision and contrast sensitivity improved, but the stereo acuity did not show a good result. Only the contrast and the BCVA.
I think somehow it's too broad. It's too broad.
I know. I mean, none of them had any squint.
No, ma'am, only
I know,
an isometric and dark. Ma'am, this was because the previous studies which have been done in my review of literature also I have seen, they included groups which were having heterogeneous groups involving strabismic amblyopia as well as anisometropic. So, since
It
it
can
was
be other way also, no? Anisometropia associated with strabismic amblyopia also.
yes, ma'am, but we included
And were all your patients that you have included in the dichoptic group had not received any form of occlusion in the past also? What I want you to clarify that all the patients that you have included were all freshly diagnosed and
Yes, ma'am. We gave freshly diagnosed, with which we first initially, once he presented to us, we gave refractive trial. Following which, after 3 months, we enrolled them in these diagnostic.
and that there had been no episode. See, if the child is presenting for the first time around 14, 15, even then, no trial of occlusion had been done in the past.
No.
Okay, so we call the next speaker, Dr. Garima Rath, studying outcomes of pediatric cataract surgery with and without triamcinolone assisted vitrectomy.
Good afternoon, everyone. So today the topic I'm going to present is studying outcomes of pediatric cataract surgery with and without triamcinolone assisted vitrectomy. This is my financial disclosure. So regarding pediatric cataract, when we talk about, it is one of the major causes of childhood blindness, and we can also call it as preventable childhood blindness. And so early diagnosis and timely treatment becomes very crucial for preventing irreversible visual impairment. And that too in in the procedure, right eye power calculation is quite difficult and confusing due to the constant change in the size of eyeball. Also, post-operatively, children have a more robust inflammatory reaction than adults, and complications like posterior synecdoche, secondary membranes are very common, and that results in the blockage of visual axis. Talking about triamcinolone, it is a water-insoluble corticosteroid which is used extensively in various fields. It has an anti-angiogenic, vasoconstrictive and anti-permeability effect. When injected intracamerally, the granules of triamcinolone acetate are trapped on the surface of the vitreous body, rendering it clearly visible. The anti-inflammatory properties control the post-operative inflammation, which is the major concern in pediatric cataract surgery. So the primary objective was to study the outcomes of pediatric cataract surgery with and without triamcinolone assisted vitrectomy, and the secondary objective was to observe for any complication that is attributable to the use of triamcinolone acetonide itself. So it was a randomized experimental study comprising of study and control groups of 26 26 pediatric patients in each group, and was carried out for 21 months. The pediatric population that we included was from 0 to 6 years. Pre-op evaluation included history taking, slit lamp examination, B-scan and IR power calculation, and we did undercorrection for IR power, and all the surgery was done by a single surgeon. Same surgical steps, exception was that the triamcinolone was used only in study. So 0.05 ml of triamcinolone was injected below the IOL in first group, and the next dose was given into the anterior chamber to stain the residual vitreous strand. Follow-up was done on day 1, 1 week, 2 week, and then 3 months and then 6 months. During post-operative visits, the anterior chamber inflammation went down to 4. So these were the results. Among the study group, the posterior synecdoche and inflammatory membrane was seen in 7 cases in control group, while it was seen in 18 cases in case of the control group. In case of study group, the inflammatory deposits were noted in 6 cases, while it was in 16 cases in case of control group. The next comes the posterior capsular opacification. Among the study group, only 2 cases had this complication, while it was seen in 10 cases in control group. This proportion of posterior capsular opacification was significantly higher in control group than the in study group than in control group than the study group, with a p-value of 0.08. The resurgery was done in cases of 2 cases in study group, while 10 patients from control group underwent resurgery. This proportion was also significant, statistically significant, with a p-value of 0.08. The post-op horizon IOP among the study group, only 5 patients had, while it was seen in 2 cases in case of control group. There was no significant association between post-operative IOP status and intraoperative triamcinolone with a p-value of 0.223. Coming to discussion part, our study to a certain degree had results that were similarly reported by Allen et al. That posterior synecdoche was seen in 4 eyes in the study group and 5 eyes in the control group. Also, in the study by N. Dixit and Vasavada et al., posterior synecdoche was observed in 4 eyes in the study group and 21 eyes in the control group. There is no much evidence about resurgery in the articles except in the study by Praveen et al., where resurgery was performed in 1 case who had developed visually significant opacification. In our study of 52 cases, no case of endophthalmitis was reported, which is similar to the findings of Alam et al., Gupta R et al., Praveen et al., N. Dixit, Vasavada et al., and Kamal M. Solomon et al. The limitation of our study was that the study population was relatively small to reach the conclusion result that restrict the expansion of our findings to the general population, and also the study was mainly hospital based, which may not accurately reflect the general population. So these are my references.
How many surgeons operated on these patients?
Ma'am, single surgeon only.
Single surgeon, because your reoperating rates are a little higher, no?
Was there some reason or some specific factors that you had considered for dividing into the case and control group, or it was randomized?
It was randomized. After taking consent from the patient and their, not patient, the guardians, we randomized the patients.
What is that? One complication you should have looked for.
The post-operative rise in IOP for.
Okay, that you have said. Anything else? Why do we use triamcinolone?
Mainly to render the vitreous strands visible.
Correct. So what you should have looked for in the
residual vitreous strands.
Anybody had vitreous not cleared completely.
Not properly cleared from the.
What IOL was used?
3-piece IOL was used.
3-piece?
3-piece PMA IOL is.
Huh?
No, ma'am.
No, you have dealt with pediatric population. What was the type of IOL used? Anything you think should have been used means IOL, the type of any preference in the pediatric population?
Was it uniformly same IOL or was there a difference in the IOL? So which can attribute to the why there was so much of a repeat surgery?
I should have looked it for it.
Okay. We call it,
Yeah. Shruti. Yeah, next we call the presenter Dr. Shruti. Shruti or Shruti? Shruti. Please come for your presentation.
Good afternoon. My case is an optic nerve aplasia in a myopic eye, which is a very rare developmental anomaly. It comprises unilateral or bilateral congenital absence of optic nerve, central retinal vessels, and retinal ganglion cells. Unilateral cases is associated with other ophthalmic abnormalities like microcornea, microphthalmus, and cataract, but the bilateral ones are commonly associated with the intracranial abnormalities. Optic nerve aplasia appears to be a part of a malformation complex that is inherently different from the optic nerve hypoplasia. However, numerous case reports in the ophthalmic literature mistakenly identify aplasia, describing it as instead hypoplasia of the optic nerve. To our knowledge, the largest series of the optic nerve aplasia was reported by Viral et al., who documented 11 unilateral cases of optic nerve aplasia and 2 atypical bilateral cases. I present a case report of a 6-year-old girl who was born to a non-consanguineous marriage, presented with complaints of inward deviation and diminution of vision in the right eye since 1 year. She had a full-term cesarean delivery and immunized up to date with no development delay. She had an 8-year-old brother with no similar complaints. On examination, it revealed absence of perception of light with mild ptosis in the right eye. The right eye had 50% diopters of esotropia with modified crimsy with overaction of inferior optic muscles. There was also microcornea in the right eye with corneal diameter measuring of 7.6 mm horizontally and 9 mm vertically. There was total afferent pupillary defect was seen in the right eye. The left eye had vision of 6/6 with normal clinical findings. Fundus of the right eye showed an avascular whitish area present at the presumed optic dislocation. There was no retinal vessel seen. Diffuse area of pigment epithelial atrophy and macular atrophy was seen, with bearing of large choroidal vessel seen. Fundus of the left eye was normal. Ultrasound B scan of the right eye showed absence of optic nerve shadow with an axial length of right eye of 24.6 mm, while that of left eye was 22.45 mm. MRI of the right eye showed absence of intraorbital and intracranial part of the right optic nerve, while the left eye had a normal optic nerve. Also in the coronal section we can see there is absence of right optic nerve. So this case summarizes the main features of aplasia of the optic nerve. Optic nerve aplasia is a rare congenital malformation that is usually associated with microphthalmos as well as with other ocular and extraocular anomalies. It likely arises from gestation insult during disrupting the retinal development and angiogenesis, leading to retinal ganglion cell degeneration. The exact cause remains elusive, although it was first described 160 years ago. There are different theories that has been proposed, like failure in mesodermal element, failure in fetal fissure formation, failure of ganglion cell development of mesodermal induction. On histopathology, it reveals a vestigial dural sheath and retinal dysplasia. There has some been role of external factors like episode of viral infection in first trimester or smoking during pregnancy. PAX6 and OTX2 genes might be involved, but the genetic basis remains unclear. The choroidal vasculature appears to be normal in optic nerve aplasia, but there is lifelong risk for choroidal neovascularization. Unilateral cases present with normal brain development, while the bilateral cases may co-occur with hormonal like congenital hypopituitarism and structural brain abnormalities like Demosh's syndrome. Esotropia, anophthalmos, microcornea and other ocular findings are more frequent with unilateral cases. Prognosis of vision is poor, with management focusing on identifying systemic issues and supporting the patient with low vision aids, prosthetics and rehabilitation. So to conclude, given the potential for associated cranial nervous system and endocrine issues in children with optic nerve aplasia, a comprehensive systemic workup including neuroimaging is warranted to ensure complete evaluation. Optic nerve hypoplasia has been reported to be associated with myopia, but this case highlights myopia associated with aplasia, indicating a possible connection between retinal signals transmitted to the central nervous system and the feedback loop regulating ocular axial length.
I have no questions.
In literature reported there is how many cases could you get
Ma'am, hypoplasia has been reported, but optic nerve aplasia as such has been reported very less. There has been a publication in the Indian Journal of Ophthalmology also. There has been 2 papers in Iran and Egypt, and one has been done, I don't remember, in US, but not much. But hypoplasia has been reported in 11 studies.
It's very common.
Very common.
Very common thing.
This thing was, we were more concerned because one of the eye was showing an axial length, but means it was going more towards the myopic side. We tried to rule out any brain abnormality, any endocrine issues. There was nothing else associated with it. But the patient had an axial length more than that of the left eye. But it has been reported with hypoplasia, myopia, but not with aplasia as such.
Call up from Dr. Kalyani.
Good afternoon everyone. Today I will be presenting through siblings eye exploring a rare presentation of pedipapillary pachychoroid syndrome. I would like to acknowledge the chief author, Dr. Soumya, and co-authors, Dr. Prabhakar, Dr. Kavita, and Dr. Shayaka. A 9-year-old girl, patient 1, was referred to Ophthalmology department for fundoscopy to rule out papillary edema. She had presented to a pediatrics OPD with complaints of headache and giddiness since 8 days and history of convulsions 1 day back. The child had one episode of involuntary jerky movements of the upper and lower limbs, which was associated with posturing, uprolling of the eyeballs, and deviation of the angle of mouth. Upon further review of the family history, the mother reported a similar condition in an older kid who is a diagnosed case of seizure disorder, who also had complaints of diminution of vision. Patient 1 had no significant past medical history. Patient 2 was a known case of seizure disorder and was on oral brivaracetam 50 mg BD. Both the siblings were born out of third-degree consanguineous marriage. There was no history of seizure disorder in any of the family members. Case 1, extraocular movements were full and free in both the eyes with plus 0.5 spherical correction in both eyes improving to 6x. IOP was normal, was 12 and 13 mm Hg right and left eye when measured with rebound tonometer. Anterior segment was normal with pupils round, regular and reactive. Posterior segment disc normal with CDR of cup disc ratio of 0.3, vessels were normal, but choroidal folds were noted present around the macula, and the macula seemed to be dragged towards the optic disc. The same examination was noted in case 2 with full and free extraocular movements, IOP normal. Anterior segment was normal as well, with posterior segment disc normal, cup disc ratio of 0.3, and choroidal folds were noted in case 2 as well. On OCT macula, it presented a normal foveal contour with increase in the nasal neurosensory retinal thickness of 682 microns on the left eye and 632 microns in the left eye, with disorganization was seen in the inner retinal layer extending from the fovea to the temporal to the optic disc, and subfoveal choroidal thickness was around 320 microns. I could not have the access to the photos of it. In patient 2 as well, who is the sibling, similar features were seen in this patient as well, with normal foveal contour, with increase in the nasal neurosensory retina, with
No torsion of the macula.
no ma'am.
Because you said that there was dragging of the macula in both the cases.
Ma'am, the macula seemed to be more closer to the optic disc as it usually is. So when seen on fundoscopy, it seemed like the macula was dragged near the optic disc. The distance between the macula and the optic disc was reduced.
Was reduced.
Yes. Thank you.
One thing that you have evaluated your patients thoroughly. What other features you were present in your patients to label them as a case of pachychoroid?
Ma'am, usually in this age group, usually you don't present with a pachychoroid spectrum. It's usually in 20s to 50s. So in this age group, when we did an ED-OCT from another center, we got the choroidal thickness, subfoveal choroidal thickness of 320 microns in both the eyes and 330 microns in the second patient. So that is why we concluded that it might be a variant of pachychoroid spectrum.
Might be a variant. Okay. Okay. Please, next speaker.
Thank you.
Aditya Ranjan. Ranjan, sir.
So, good afternoon. My presentation is on torch and insight into pediatric cataracts. There are no financial interests for this purpose. So, congenital cataracts, they significantly impact visual development and they often lead to amblyopia, strabismus and long-term visual impairment. They are substantially more challenging than senile cataracts and they pose a huge financial and psychosocial burden on the affected families. Developing countries like India have a high incidence, almost 5 to 15 per 10,000 live births, which is 2 to 3 times as compared to developed nations. The various etiologies include infections, metabolic causes, familial cases, trauma, and intrauterine radiation exposure. So torch infections, they attribute almost 20 to 35% cases of congenital cataract according to different studies. And routine vaccination is performed only against rubella. And the burden of disease caused by the various torch infections in a differential manner will help in planning better implementation of existing resources. So the aim of the study was to estimate the proportion of various torch infections associated with childhood cataracts presenting to a tertiary care center in eastern India. It was a hospital-based cross-sectional study. Duration was from January 2022 to January 2024. The study population consisted of patients with cataract aged less than 18 years presenting to the OPD of AIIMS Patna, and the sampling technique was purposive sampling. So total number of patients who presented to our OPD under the age of 18 years with cataract were 129, and cases of traumatic and secondary cataract were excluded. We were left with 38 patients, out of which 8 were lost to follow-up, and the final number of patients included in the study was 30. So chemiluminescence immunoassay CLIA was performed for rubella, CMV and toxoplasma, whereas ELISA was performed to test IgM antibodies against HSV1 and HSV2. So the results included the mean age of the presenting population was 4.6 years, and it ranged from 4 months to 14 years. There was a high preponderance of male subjects, almost 70%, and most of the cases were bilateral, 93% cases out of 30. So as this graph shows, most of the patients, 23 out of 30 children, they tested seropositive for antibodies against IgG antibodies against CMV, whereas 13 tested positive for IgG antibodies against rubella, while only 2 tested positive for IgG against toxo, and none of the patients they tested positive for HSV, IgG or IgM. So high rate of presence of IgG antibodies against CMV indicates high rate of previous infection, and Singh et al. In their study found that almost 33% of childhood cataract cases tested positive for torch infection, while in our case almost 25 out of 30 patients, 83% patients tested positive for antibodies against one or more torch pathogens. And in a study conducted by Das Gupta et al., 91% tested seropositive for one or more torch pathogens, so which was also seen in our study. The limitations of the study being it was a hospital-based study with a small sample size which might not be representative of a larger population, and qualitative serological assessment of antibodies against torch pathogens was done, while quantitative trends of antibodies would have been a stronger predictor of infection. So the take-home message here is the high rate of seropositivity against CMV in childhood cataract cases presenting to our center may be an indicator of larger role of CMV in certain populations, and larger population-based case control studies are needed. Though larger population-based case control studies are needed to establish causation in these populations of actually CMV causing congenital cataract in these populations, we need to conduct more studies to actually establish a cause-effect relationship and implement resources such as vaccination or medical management in pregnant women to reduce the incidence of congenital cataract in these patients.
What is the difference in the post-operative outcomes that you have observed in those groups which had positive and others?
We did not, in this study we did not compare the post-operative results, but
How many of the kids received IDCMT3?
because only 2 tested positive for CMV IgM. IgG was present in 23, only 2 have tested positive for IgM, so only 2 received therapy.
But do you think that CME is that common in other places? Is it the population you have tested is from
From Bihar.
Bihar, na? So is it something, there's something to do with some endemicity with this CMV? Otherwise, we don't find that much toxo, you can say, or others. But CMV, I don't think that is that common. That did you search
we
for
were
the
expecting, yes, ma'am. Actually, seroprevalence against CMV is high in many parts of the country, including there was one study conducted on women of reproductive age group. So, and children also, there was a different study which was conducted on children under the age of 18 years. And in both the studies, the seroprevalence of CMV was almost as high as 80%.
How many of them had maternal positive history of xanthomatosis fever in antenatal period?
There is a recall bias in such cases, so only 3 or 4 mothers, they said that they had a history of rash.
They had?
Yes. Thank you.
Shamika.
Shamika.
I'll be taking you through a tale of shaky eyes and stiff bones. My aim is to report a rare case of foveal hypoplasia with nystagmus in a patient with autosomal dominant osteopetrosis. Osteopetrosis is a hereditary metabolic bone disease with increased density and brittle bones. Severe cases can be presenting with pathological fractures, pancytopenia, cranial neuropathies, and hepatosplenomegaly. Foveal hypoplasia is when the foveal pit does not develop fully. It can be associated with poor vision and nystagmus, and it is seen commonly in conditions of albinism, aniridia, coloboma, optic nerve hypoplasia, and retinopathy of prematurity. Variants in genes associated with osteopetrosis are as follows, and the genes associated with foveal hypoplasia are as follows. Most common visual association of osteopetrosis is that of optic nerve atrophy due to optic canal stenosis following bony sclerosis. My case is that of a 10-year-old female presenting to the OPD with complaints of involuntary shaking of both eyes associated with decreased vision since birth, no history of consanguinity or any other systemic illnesses, antenatal and perinatal history were unremarkable, and age-appropriate developmental milestones were achieved. On examination, she had bilateral horizontal jerky nystagmus, which was left beating in moderate in amplitude and frequency and dampened on right face turn. On Hirschberg, she had right exotropia of 30 degrees, and on cover test, she had right exotropia with left eye fixation preference. On prism bar cover test, she had 30 prism diopters of base in for distance and 20 prism diopters base in for near. Her best corrected visual acuity was 636 N6 in the right eye and 618 N6 in the left eye with refractive correction. Her color vision was 2/21 in both eyes. Her applanation tonometry showed pressures of 16 in right eye, 15 in the left eye. Pupils were round, regular, reacting to light in both eyes, and extraocular movements were full, free, painless. Anterior segment examination was within normal limits, but the posterior segment showed a marked temporal pallor of the disc, absent foveal reflex, and a normal background and vasculature. We did ancillary testing, which was OCT, optical coherence tomography, which confirmed our suspicion of foveal hypoplasia. There was absence of foveal pit seen in both eyes, with asymmetrical shallow foveal contour seen, right thicker than the left. The temporal pallor led us to ordering MRI brain and OCT for the patient. On axial T2, we could see thin optic nerves and chiasm, and there was also a finding of diffuse calvarial thickening. This led the radiologist to suspect osteopetrosis or pycnodysostoses, for which she suggested more radiological imaging, and we did X-rays for the patient. The X-ray images showed skull lateral view, showed diffuse sclerosis with skull base thickening. Spine lateral view showed rugger jersey spine with hyperostotic vertebral end plates, and there was bone and bone appearance in the leg bones. Pediatric evaluation, systemic evaluation was within normal limits, and blood tests were also within normal limits. To confirm diagnosis of osteopetrosis, we did genetic evaluation, and a heterozygous missense variation was detected in exon 11 of the CLCN7 gene, which was likely pathogenic for autosomal dominant type 2 osteopetrosis. The variant was C937GA or P-GLU313-LIS, which results in the amino acid substitution of lysine for glutamic acid at codon 313. My diagnosis was that of foveal hypoplasia along with autosomal dominant type 2 osteopetrosis. We managed the patient conservatively by giving her yolk prism trial, and prism glasses were prescribed, and vitamin D supplementation was given by the pediatrician. This case shows a novel genetic presentation involving C937GA variant encoded in the CLCM gene, which is very scarcely reported in the literature. Wang et al. Reported similar variant associated with severe fractures, but in their study only one patient became blind and was diagnosed with optic atrophy. None of the other patients had visual deterioration or loss over time, and visual loss, they suggested, were due to bone remodeling due to optic canal caliber in childhood. So this case is the first to show an atypical presentation of foveal hypoplasia with clinically and genetically diagnosed autosomal dominant osteopetrosis. Similar nucleotide variants can present with different severity of phenotypes, and further studies can be done to evaluate the role of exome sequencing in clinically suspicious osteopetrosis to better classify variants of this disorder. These are my references. I would like to acknowledge. Thank you.
Presenting on role of parenteral smoking in myopia systematic review.
नहीं मैं आपको व्हाट्सएप करूँगा ना, मैं आपको व्हाट्सएप करूँगा जो
As
मुझे
we know
भेजेंगे
that
जैसे
with
पहले
the current myopia epidemic, it is predicted by 2050 the number of myopes will be half of the world population. Parenteral smoking has been shown to be associated with refractive error, and literature shows a mixed effect on development of myopia. This systematic review evaluates the current evidence on the role of parenteral smoking in childhood myopia. This protocol was registered in Prospero. Search was done across 3 databases, that is Scopus, PubMed and Web of Science, and search strategy was run through the databases using appropriate Boolean operators with following keywords: parenteral smoking, maternal smoking, paternal smoking, myopia children, and risk factors. The studies which had children under the age of 18 and association between parenteral smoking and childhood myopia were studied were included in this systematic review. PRISMA 2020 guidelines and risk of bias was assessed using Newcastle-Ottawa scale. This is the PRISMA chart. Initially 91 studies were identified and duplicates were removed, and then we screened the abstract and the title, and 33 studies were removed, and then full text of all the studies was retrieved, and finally 16 studies qualified according to the inclusion and exclusion criteria. The data extraction was done in an Excel format based on the predefined criteria, that is the patient demographic characteristics, exposure criteria, what was the smoking type and frequency, myopia diagnosis, whether the confounding factors were adjusted or not, the study results, and what was the quality of the study and risk of bias. Now coming to the results, the sample size varied from 300 to 12,000 children, and the studies were mainly based in China, Hong Kong, Singapore, UK and United States. 12 studies were cross-sectional studies and 4 were longitudinal cohort studies. The spherical equivalent which was there in these studies as a definition of myopia was less than or equal to -0.5, and 11 studies used cycloplegic refraction as a diagnosis for myopia and 5 used non-cycloplegic refraction. All the 16 studies adjusted for compounders which are commonly present like age, gender, parental education, parental myopia and socioeconomic status. The exposure was collected through self-reported questionnaires in most of the studies, and only 5 studies they used a validated biomarker in terms of measurement of the urinary creatinine levels. The studies varied in measurement of the smoking exposure. Some measured the maternal smoking during pregnancy, some measured the current smoking, and some household smoking frequency. Finally, the 10 studies were identified as showing protective association in terms of lower myopia prevalence and higher hypermetropia prevalence. 6 studies showed that secondhand smoke exposure can lead to increase in axial length and more myopia. And it was shown that the children who are exposed to high daily cigarette crowns demonstrated a high degree of severe myopia, odds ratio varying between 1.8 to 2.9 for every additional 10 cigarettes smoked daily. The risk of bias was assessed by Newcastle-Ottawa scale, and it was shown that the quality of studies, 9 studies was high, 5 was moderate and 2 were low. The limitation of the evidence in terms of the studies which were included were that there was a self-reported of the parental smoking habits which can introduce a recall bias. The incorporation of biomarkers in terms of urinary continence was not universally done, and cross-sectional model of the 12 studies which were included, it limits the establishment of causality, and we need longitudinal cohort design for causal inference. The current review, we excluded non-English studies, so language bias was introduced and unpublished literature was not included, so publication bias was introduced, and there was a variability in the measurement of outcome. So this shows an in-depth analysis of association between parental smoking and childhood myopia. This indicates a potential link between the two, but the evidence still remains mixed, and future studies in terms of longitudinal design and standardized diagnostic criteria are need of the hour, and people should be educated about the risk of second-hand smoking in causing ocular health issues in children. Thank you.
I think you mentioned in one slide, but I think I just want to be sure that how was causal association going on? You had mentioned it in one of your slides.
Because many of the studies were of cross-sectional design, so we cannot establish a causality. Only when it's a longitudinal cohort design that can be established, and only 4 studies were of longitudinal cohort design.
Okay, so only in 4 out of the 12 studies.
Longitudinal study design was there, other was cross-sectional. There was adjustment of confounders in all the studies, like age, gender, parental smoking, and parental